Did anyone say Happy Kansas Day yet today? John talked to me about 3 times before I agreed to be here today, and I think because he was after somebody that would speak that would be shorter than him. And I think that's why he did that. If this was a support group, I would start off by saying something like, "My name is Monte Coffman, and I'm a nursing home administrator." And you might say, "Well, you don't look like one." Well, I am one. And the discussion today about palliative care is so broad. I'm reminded of a mosaic of a painting, and a beautiful painting is made up of literally thousands of individual brush strokes that, when come together, make something beautiful. And I think that's what we're talking. There are so many moving parts and contributors to a great end of life, and certainly we've hit on those. Kathy, you have your hands full. If you take this back and whatever you want to do with that. I've been at my institution 22 years, and we start off by the belief that nursing homes are dark places, and our job has been and is to unbecome a nursing home. And certainly Dr. Lynn and Dr. Miller, I appreciated your early remarks about the supports and services of long-term care. My first day on the job literally was April 1st, 1992. And the joke has been on me ever since. By the end of the first year, we had golden retrievers, 3 of them, that had run of our place. We had a 163-bed skilled nursing facility. Because that's what people had at home. If we're going to create home, and if we're going to create an atmosphere where people feel comfortable and free, then we have to provide some of these things. We've done weekend Meals on Wheels. The federal program locally is, I'm in southeast Kansas in a rural community of about 10,000 people. But we provide weekend Meals on Wheels. I never could quite figure out why people got the cold frozen bricks on Friday for Saturday and Sunday, when we're making a lot of food anyway. So for us to meet those critical needs where persons who need the supports don't have families in proximity, that's where we can fill a gap. But I think as we continue to provide supports, it's underwritten by the principle that people should have control and make choices in all areas of their life, from who their caregivers are in the building to what kind of a bathing experience they have, how frequently that is, who does it, to when I eat, to when I wake up, to what I eat. So our program is saturated with those philosophies that we believe support end-of-life environment. So much loss has taken place. In many institutions, further loss has taken place because of the processes. We believe intentionally we need to give back to that person. We went to the Maverick Secretary of Aging that was in Kansas in 2006 and asked for permission to put an all-day, everyday kindergarten embedded in our facility. She said that was a terrific idea, and she ran some interference and assisted with that. And so we're in our 6th year of having an all-day, everyday kindergarten. The first year we had a full class, 21 students, but we barely got there. From that year forward, it has been a lottery draw. Word of mouth from within the community, the families want their children there. And what's been amazing is the transformation that's been able to happen for all of the groups involved. Obviously for the residents to have that life and that energy that brings back so many memories that they can still contribute to another life. But for the children who get to be loved on and hugged on, plus the dinner conversations that can happen within the family from the experiences. And certainly that every year children have experienced the death of residents that they've become close to. And the age-appropriate discussions that's been able to take place. And then as those are expanded into the families, because we include the families in that conversation, really does, in our corner of the world, change what dying and choosing well at the end of life can mean. We know that nobody wants to go to a nursing home. So we have an arm that we started in 1996 that's a home and community-based service. We provide supports and services to about 1,300 persons in their homes. We went back to the aforementioned Maverick Secretary of Aging and she was gracious enough to give us some seed money to start a telehealth and a remote patient monitoring service in the home, targeted toward persons with chronic disease conditions. And many of these persons, and again, the application to this setting is those, whether it be diabetes, hypertension, congestive heart failure, COPD, or secondary. They're chronic, but they probably are secondary to the terminal illness. And we've been able to support those persons in the 3-year study that KU Med Center did. We had it not as big as some of the other studies. We had 109 people in the study, 3.2 chronic disease conditions. And we reduced, over a 3-year period, hospitalizations by 40% and emergency room visits by 2/3. And the pre and post claims comparison saved $26,000 per person per year in the 3-year study. So it wasn't like we had a really good month or really good quarter. But what that does is, it was mentioned in the earlier panels this morning, it keeps that traumatic movement from the institution back home, back and back, so we can support the palliative care strategies that's going on within that home with that family for that person. Probably the last thing we've been able to contribute as a long-term care organization is we have sponsored a series, and we have scheduled again another series here in 2014, community meetings in a public place, not on our campus, around the video Consider the Conversation, where people in a non-threatening way can start to deal with these things way before there's a need. Because long-term care, maybe even health needs, it's such a needs-driven business. We don't deal with it until we have an immediate need. And we have to do our part to try to break that down. But that's what we're doing in the area of long-term care services and supports.